Good afternoon. I'm Steve Higgins, and I want to welcome you to the final lecture for this fall semester in the Vermont Center on Behavior and Health lecture series. And in way of housekeeping, I want to let you know, of course, we will be picking up in January, January 21st, to be specific, with a lecture from David Farabee. And of course, we'll have the holidays in between. So I want to wish everybody a wonderful holiday season. And one more thing in housekeeping, we're going to have about a 40 to 45-minute lecture today, and there will be a Q&A session afterwards. So use the Q&A button to send in your questions during the presentation. So we're fortunate to have one of Vermont Center on Behavior and Health's own today. So I'm really excited about that. Eli Klemperer, in way of he's an associate professor here in UVM's departments of psychiatry and psychological science. He's also the associate director of the Vermont Center on Behavior and Health. So he wears multiple hats. And in way of background, Eli completed his undergraduate training in the Lewis and Clark College in Portland, Oregon. I always get a little envious when I've never been to that site, but it sounds like a wonderful college especially for undergraduate. And then he completed his doctoral training here at the University of Vermont, where he was a member of our NIDA T32 and was mentored by John Hughes, an esteemed scientist and great mentor. And the doctorate was in clinical psychology, if I didn't say that. Then he went to the Yale School of Medicine for a one-year clinical internship before returning to VCBH in the University of Vermont for his postdoctoral training, where, if I'm recalling correctly, it was a mix between Andrea Volante and John Hughes as mentors, and very collaborative and productive. And then on to the UVM faculty, where he quickly rose through the rank to what he is currently an associate professor. He already has two R01s to his credit and a third under review, so he is truly going gangbusters. I like to say he's one of our field's rising stars. I think he is continuing to rise. So I'm really excited about it. Best example of a recent award for scientific excellence is he is the 2025 recipient of the SR&T Society for Research in Nicotine and Tobacco Jarvik Russell New Investigator Award. He publishes regularly in well-regarded journals in tobacco regulatory science and tobacco control. He is just active across the tobacco field. And I wrote it down today so I don't forget, but he is speaking to us today on the strategies to promote quitting in adults not engaged in treatment, which of course, quitting smoking, because most current smokers are not engaged in treatment. And so it's an extremely important population to attend to. So Eli, with that, I'm going to turn it over to you.
Well, thanks so much, Steve, for that very warm introduction and welcome here. I'm really excited to be giving this talk today. I'm going to start by trying to share my screen here. Can you see that, Steve? Can you just give me a thumbs up if you do? Yeah, okay, great. All right, yeah, so as Steve mentioned, I'll be talking to you today about working with adults who smoke and are not engaged in treatment with a focus on reduction strategies, cutting down to quit here. So I'll just dive right in. I have quite a few slides to get through today. Here's a disclosure for continuing education. And here's my personal disclosure. I have no conflicts of interest to disclose. So the outline I'd like to get through today focuses first on understanding readiness to quit smoking as a construct and what we know about adults in the US who smoke and their readiness to engage in a quit attempt and treatment. And then I want to focus on a topic I've spent some time thinking about, which is strategies to promote reducing cigarettes per day or cutting down on the number of cigarettes smoked. And then I'll transition to talking about a different form of reduction, related but distinct, which is cutting down on the nicotine in cigarettes, which is an FDA proposed regulatory strategy, but as I'll talk about later, may also have some clinical application. And then finally, as Steve mentioned, we'll have some time at the end for questions and discussion. So I like to start with this slide. In most talks I give, we all know on this call that smoking is bad, but I think just how bad is often forgotten, the magnitude of the harm. And so presenting this, I think, grounds the entire talk, or really, most topics in this area with what we're talking about here. So, worldwide, over 7 million premature deaths annually, nearly 500,000 of those in the US. And on an individual level, around a 50% chance of premature death from continued smoking, all from combusted tobacco. The upside is cessation can reduce risk of premature death and disease by about 90%. And this is all the backdrop to the fact that smoking remains the single most preventable cause of premature death. And so it's an important topic and one that I spend my days thinking about. Okay, so readiness to quit smoking. What we know is that nationally representative samples indicate that most people who smoke are somewhat familiar with that fact that smoking is bad. They don't, and for other reasons as well, they don't want to continue smoking for the duration of their life. Most people want to quit someday. Along with that is this stat that few are ready to do so in the next 30 days. So less than 15% have a plan to quit in the next month. So it results in this population of adults saying, yes, I want to quit someday, but don't make me quit today, or don't make me quit in this next month. And I like to refer to this as as readiness because I think there are lots of different reasons one can not have a quit date set in the next month. It can be low motivation, low willingness, issues with self-efficacy and perceived ability to do so. So I use this all-encompassing term when I can remember to, of readiness to quit smoking. Now, given this, it's important to note that most smoking cessation treatments, most evidence-based treatments are designed for people who are planning to quit now. Treatments intending to increase the likelihood of long-term success. And so combined, low readiness to quit is often a common barrier to both accessing treatment, given they're designed for people motivated to quit, and also achieving longer-term cessation. So this leaves us with the question of, well, how do we address smoking among the 85% or so of adults who are not motivated to quit at any given time? Well, we can do nothing. As a provider, we could give brief advice to quit. We could simply say, well, you really should quit. We can recommend coming back when you are ready to change, which historically has been a common approach to say, come back to me when you're ready. We could target motivation as the barrier to quitting. So, classic motivational interviewing, 5 Rs, brief intervention. So if people are not motivated, we perceive that as the barrier to quitting and target that as the construct. And then there are numerous other approaches that I'll get into a little bit here in today's talk. But in order to, answer this question here, I think it's first important to start to think more in a more detailed way around what motivation or readiness to quit looks like and how that changes and how it's correlated with actual behavior. And so to do that, there we go. I want to turn to some of John Hughes' work. And, as Steve mentioned, John was my mentor. We lost him. He passed away a few years ago, but his legacy lives on through much of his work. But what I want to talk about today is his natural history research. And so here he did a series of papers, one of which I have displayed on the screen, where he simply asked adults who smoke every night over a period of months what they did that day, how much they smoked, whether they intended to quit, and whether they did in fact make a quit attempt. And out of this came some very rich data to understand how motivation fluctuates and how it's related to actual behavior change. So as I mentioned, this type of research, these methodologies are very useful in understanding day-to-day patterns and also identifying proximal predictors of change like motivation or readiness. It also is a way to increase sensitivity. So we did a couple of secondary analyses on one of his natural history studies that found that actually investigating questions using day-to-day data reduces the likelihood of false negatives compared to traditional monthly follow-ups. So, another way to say that is it's more sensitive to signals that are actually there than some of these longer-term follow-ups. Increased recall accuracy. There's a methodological benefit here. John found in at least one of these natural history studies that up to 40% of brief quit attempts that were reported on nightly surveys were not reported at the end of the trial at 3-month follow-up, indicating that either individuals didn't think they were worth mentioning or for some reason didn't recall. And ultimately, I think this methodology is a very useful way for us to start to understand tobacco use and identify targets for interventions, especially among individuals who may not be engaged in treatment or ready to quit now. So to give an example of this is completely made up data you see here on the screen. We have a hypothetical participant going from 20 cigarettes per day at baseline to 5 cigarettes per day at, say, a month follow-up. And we often are tempted, I do this as well, draw a straight line from point 1 to point 2. We say, great, we have some reduction and try to interpret that. But what we might be missing in this is all the variability that we can pick up with things like nightly surveys or natural history methodology. And so, I've just superimposed on this one hypothetical example of changes in cigarettes per day for an individual over that same time period, which you can imagine would identify targets for intervention or greater understanding of how smoking is actually how cigarettes are actually smoked in the real world. And then, of course, layer on top of this daily data on quit intentions, quit attempts, other sources of nicotine, environmental cues, internal cues like emotion. You get this very rich data set to understand people in the real world who are not engaged in treatment. And so out of this, you can build pixel graphs, which I'm sure many on the call are familiar with. But here's an example of one that John and I put together from one of his natural history studies. And just to orient you to the graph here, this is a group of adults who are smoking cigarettes. Each row represents an individual participant. Each column represents a day. And so from left to right is the passage of time. And the pixels represent what happened on that day. And so to give you an example of a sample of adults who smoke fewer cigarettes on top and more on the bottom, you can see those light gray boxes represent a day of reduction of up to 24%. Darker gray represents reduction of 25 to 50%. Darker still is greater than 50% reduction in cigarettes per day. Now, importantly, an I represents a day when that individual intended to quit smoking, indicating readiness to quit or ready to become engaged. Check boxes represent a day when the participant actually made a quit attempt, attempted to quit smoking. Black represents cigarette abstinence. So what you can see is this group of adults, all of whom at baseline were not motivated to quit, fluctuates quite a bit in terms of the amount that they're smoking, intention to quit, actual quit attempts, and then successful abstinence. And you can see that, quit attempts occur in the absence of intention, and intention occurs in the absence of making a quit attempt. So what does this tell us? Well, I'm going to zoom out and try to summarize a few key points from this body of literature as a whole, rather than focus on each individual study. First and foremost, I think from the series of papers that I've listed at the bottom there, we see some strong evidence that changes in intention to quit, reduction in smoking, and quit attempts are frequent. So there's not this sort of stability that can be easy to assume when dealing with a population of adults who smoke. And from that, we also see that intention to quit was a strong predictor of quit attempts. But many quit attempts occurred in the absence of intention to quit. So an odds ratio describes the relative likelihood, but because intention was so infrequent, the absolute frequency of quit attempts, it was pretty common for that to occur in the absence of motivation to quit. So what this tells me as a clinician is if I have someone in my office who intends to quit, that's great. There's likely going to be a quit attempt to follow at some point. If I have someone who does not intend to quit, that's okay too. There's likely still going to be a quit attempt to occur at some point in the future. And importantly, failed quit attempts predicted subsequent quit attempts and quit success. So this, saying if you don't quit, keep trying, try again, is really supported by these data. Failed quit attempts were a step in the right direction. So all of this together really drives home for me this notion that we need not wait for people to become motivated in order to promote smoking cessation. And this idea has been talked about quite a bit uh, uh, between Tim Baker's framework for tobacco dependence treatment, as well as Jim Prochaska's trans-theoretical model of change. This notion that someone does not need to be motivated right now when you see them in their office in order to receive effective intervention, I think is important for us as a field. And so to graphically represent this, perhaps traditional treatment focuses on transitioning from smoking to smoking cessation. But here we're talking about focusing specifically on getting over the hump from smoking to quit attempts, specifically among people who at any given point in time may not be ready. And this is important because there have been a number of secondary analyses now indicating that the mechanisms responsible for transitioning someone from smoking to simply initiating a quit attempt differ from the mechanisms responsible from transitioning from a quit attempt to longer-term cessation. So a few years ago, we took this idea and said, well, what are the interventions out there that have specifically tested treatments to induce quit attempts among people who are not initially motivated to quit, just to try to collate the literature and see what has been done on this specific topic. So we ended up reviewing about a little less than 2,500 articles and included 25 randomized clinical trials in this systematic review. And importantly, quite a few, as you can see in that box highlighted in red there, quite a few studies were excluded simply because they didn't report on quit attempts as an outcome. So they may have been designed to increase motivation to quit or increase cessation long term, but this outcome of measuring that first phase or that motivation phase, getting to quit attempts, wasn't in those. So we ended up with 25 studies. And before I present to you a quick snapshot of the outcomes, I'll just jump straight to the take-home message here. We found a very wide range of interventions testing the ability to get from smoking to simply initiating a quit attempt. And each had fairly inconsistent findings. So this was a fairly inconsistent message from this review, but I think gives a nice snapshot of the literature at this point. So we identified motivational counseling interventions. We identified reduction counseling, combined motivation and reduction counseling interventions, very low nicotine content cigarettes, NRT in the absence of counseling, NRT with reduction counseling, with motivation counseling, with both combined, and then varenicline, all to induce quit attempts among people not motivated to quit. From this, I think we got a snapshot of the current literature finding substantial heterogeneity in interventions that have been tested to address this issue, with outcomes in each individual meta-analysis fairly varied and inconsistent. So we really did not have sufficient evidence to determine the effectiveness of any single intervention, but it really demonstrated the need for tobacco treatment trials to report both quit attempts and quit success, and to develop this area further with interventions specifically targeting folks who are not ready to quit. So, from there, I want to talk a bit about one of those areas of intervention that I've spent some time working on. But just to be clear, I think there are multiple promising avenues here. This is one that I've been thinking about quite a bit. So I'll start here with reducing cigarettes per day as a strategy to increase quitting. So, I think this is an important approach because it's something that people who are not motivated to quit commonly resort to. So guidelines often recommend picking a quit day and quitting abruptly, but even among those who do engage in a quit attempt, we see at least half who report reducing in advance of quitting. And it's an interesting question because there's a logical explanation that reduction could be a foot in the door here. It could be a way of promoting quitting among people who at baseline are not motivated to quit, but it also could delay quitting. So if reduction occurred and prevented someone from actually engaging in a quit attempt who otherwise would have quit abruptly, that could be a harmful thing. So a topic worth exploring. There are some there are a number of trials that demonstrate some efficacy of pharmacotherapy-aided reduction, but it's not clear whether it's the pharmacotherapy or the reduction per se that increases the likelihood of quitting among those not motivated to quit at baseline. And it's an important question to tease out because it's very difficult to, or sometimes difficult to get folks who are not ready to quit to engage in smoking cessation pharmacotherapy. So important to understand the role of reduction per se. So as a first step, again, we turn to the literature here. At the time of this review, this was about 10 years ago now, there were not, we had trouble finding RCTs on reduction counseling in the absence of medication. So in order to try to understand the causal link between reduction and quitting, we asked, is there a dose-response relationship between magnitude of reduction and probability of quitting? And if there was a causal link, you would expect to see greater reductions leading to a greater likelihood of quitting. So we looked in the literature to see if that signal existed. We reviewed 104 articles, 11 of which did test a dose-response relationship, often as secondary post hoc analyses. But we pulled those papers together just to get a tally of, is this a signal that studies are finding in their data? So you can see those papers here on the screen. You'll note that most of the trials, or actually all of the trials, did include some pharmacotherapy. And you can see on the right column there, just a simple tally of whether this signal of a dose-response relationship was reported. And then of those that gave some detail on the effect size, what that effect size looked like. So in the RCTs, the odds ratios are relatively small, but the unit was a 1 cigarette per day decrease. So we're seeing, for every cigarette decreased, about a 3 to 4% increase in the odds of engaging in a quit. And then those effect sizes are larger, but with larger units for the observational studies. So today I wanted to focus on those not ready to quit and whether reduction might move the needle on that group. And so I split this sample, just a simple tally. So on the left, those are the studies that recruited participants who were motivated to quit at baseline. On the right, those are the studies that recruited participants, or at least the analyses that included participants not ready to quit at baseline. And you can see that this signal exists in the majority of studies in both categories here. So, it comes with a lot of caveats. These were primarily secondary post hoc analyses, self-selected reduction, but it was a signal early on that maybe we have something here. And so from there, we asked the same question, but now with a very different methodology, coming back to natural history research. But this time asking, on day-to-day measurements of smoking, do we see a dose-response relationship between the magnitude of reduction in smoking and the probability of making a quit attempt on the very next day after a reduction episode? So here we had a sample with 132 adults who smoked cigarettes. They reported nightly cigarettes per day, quit attempts, intention to quit for 12 consecutive weeks. We provided no treatment. And importantly, I only identified the reduction interventions where at the the reduction episodes, where at the beginning of the episode, participants said, yes, I am cutting down on my smoking, but no, I do not intend to quit. So they presumably were reducing for some other reason. And then measured consecutive days of reduction and tested whether the percent reduction, absolute reduction, duration of reduction, and then cigarettes per day at the end of an episode predicted quitting. And so what we found was no matter how we measured reducing, there was a consistent dose-response relationship where greater magnitudes of reduction was associated with making a quit attempt on the very next day among people who at the beginning of the reduction episode said they did not intend to quit. So I found this interesting and compelling that at least self-selected reduction, people who chose to engage in this, was moving the needle on engaging in that quit attempt, again, among people who were not in treatment. Okay, so from there we moved on to the real test of this question. A rigorous test of this question, I should say. A randomized clinical trial where we assign people to reduce versus prior papers I was talking about self-selection and whether there was an association there. Here we're randomizing people to 3 different interventions, one of which is reduction counseling. And just to give you a quick snapshot of this paper, this was 560 adults across the US. They smoked 10 or more cigarettes per day. At baseline, none of them had any motivation, or none of them had a desire to quit in the next 30 days. And it was a fully remote design. Treatment lasted 3 weeks. We had a motivational condition, which was the brief 5 hours counseling. We had a brief advice condition, which was simply advising participants that they really should quit smoking. And then we had our reduction condition, which is what I'll be focused on today, which was 3 counseling sessions that offered either a timed reduction or hierarchical reduction intervention, depending on participant preferences, which is essentially 2 validated ways of getting people to cut down on their smoking in a sort of a systematic way. We measured outcomes at 6 months, and jumping straight to the results here, these were non-significant. We were surprised to see that there was really no signal when it came to promoting quit attempts between the control or intervention conditions, with reduction counseling in the green there. And then when it came to 7-day point prevalence abstinence at the 6-month follow-up, we did see numerically some signal, but again, this was not statistically significant, and it was a fully powered sample here. So a bit of a head scratcher. We saw this relationship with self-selected reduction, not able to get it when we randomized participants to counseling. But again, secondary analyses, which were published after the fact, saw this nice orderly dose response relationship where among those who self-selected larger magnitudes of reduction, we did see a greater odds of quitting at the 6-month follow-up. And also greater odds of success with 7-day point prevalence abstinence at the 6-month follow-up. So, we're seeing self-selected reduction strongly associated with quitting, but not able to induce that in an experimental setting. So more recently, a doctoral student, Tony Barrows, who was previously in our center as a research assistant, conducted a latent class analysis of 5 randomized clinical trials of NRT-aided reduction for 6 months to try to understand is there a threshold for the amount of reduction necessary before someone actually succeeds at quitting. He had a little over 2,000 participants in this analysis, and the outcome here was CO verified smoking cessation at 12 months. Participants received NRT for 6 months. And he reported on a number of interesting findings here, but one I want to focus on is the latent class trajectories. So he ended up with 3 classes here. The red represents participants, about 10% of the sample, that are sort of our super reducers. They reacted very well to this NRT-aided reduction intervention and reduced, near 70–80% of their cigarettes per day. Class 2 turned out to be our sort of moderate reducers. They hovered right around 50% reduction for the treatment period. And class 3 was sort of our minimal reducers. They did reduce some in the beginning responding to treatment, but ultimately ended up to close to no change in their cigarette smoking. And what he found in his next set of analyses was that class 1 and class 2 had a 90% increase in the odds of achieving smoking cessation at the 12-month follow-up. So, a common outcome for reduction trials is a 50% reduction. And here he's showing if you can get around that 50, it's actually 46% here in class 2. But if you can get below, if you can reduce by about 46 to 50% or more, that's where we're really starting to see the effects in this sample of people who are not motivated to quit smoking at baseline. So I think this is really interesting stuff, just accepted for publication. So keep an eye out for that paper coming out soon here. Finally, the last thing I want to say about reduction interventions was working with the Cochrane group here in a meta-analysis published a few years ago, where it really took a broad scope looking at all the RCTs that have tested reduction versus abrupt cessation, including the one that I presented earlier, but many others. And there are varied results, but combined, what we see is with over 22,000 participants, a risk ratio of exactly 1.0, indicating that reduction interventions compared to quitting abruptly did not appear to be any worse than interventions to quit abruptly. So you'll notice I said that sort of in a positive way for reduction interventions. To me, this is encouraging. What it tells me is at the broadest level, if we're looking at all these RCTs, if a participant or a patient comes in and is not ready to engage in an abrupt quit attempt, we can at least be somewhat confident we're not going to do harm by offering a reduction intervention to get them engaged in quitting and in future treatment. Okay, so I want to switch gears here now and talk about a related but distinct form of reduction, which is switching to very low nicotine content cigarettes. And you all are likely familiar with VLNC cigarettes, given that the FDA has proposed a nicotine reduction standard, which is very exciting, supported by a number of rigorous clinical trials, some of which were conducted here in our center. And at the population level, this has potential for tremendous impact in reducing death and disease from smoking. And today I want to talk about a couple of secondary analyses I've done on these trials to try to identify whether there could be some benefit to quitting in a clinical capacity among people who at baseline were not motivated to quit. So the first secondary analysis was on a trial published by Dorothy Hatsukami and colleagues in 2018. And here there were 1,250 participants who at baseline were not motivated to quit. And they were randomized to one of three conditions. Now, the first was to immediately switch to these very low nicotine content cigarettes, so about 95% less nicotine than standard cigarettes. The second was to gradually taper down to that same level, but over the course of 20 weeks, get down to that VLNC cigarette level. And then the third was to continue smoking, quote, normal nicotine cigarettes, or cigarettes that were pretty close to usual brand nicotine content. Now, their primary finding was that the greatest reduction occurred in the immediate reduction condition. So this group here experienced the greatest reduction in cigarettes per day. And in the secondary analysis, we looked at specifically what happened during this follow-up period, noting that at baseline, no one intended to quit. And at this follow-up period, no one all study product was discontinued. So participants had the option to either resume smoking their usual brand cigarette or cut down or quit smoking altogether. And we wanted to know what happened here. So use linear logistic and Poisson regression for abstinence outcomes. In the non-abstinence outcomes, we examined the subset who did not achieve abstinence at week 24. Now, it's worth noting that in the primary paper, there's some difference in the amount of dropout. This is likely because the immediate reduction was somewhat less acceptable or more difficult for participants in the study. And so for this reason, we examined findings both treating missing as smoking as well as treating missing with multiple imputation and sensitivity analyses. And I'll present both here. Okay, so looking first at CO verified 7-day point prevalence abstinence at the follow-up period. Again, remembering these were folks who did not intend to quit at baseline, no experimental product during follow-up. You can see that when we treat missing as smoking, there are no significant effects, but you do see some numerical difference there favoring the VLNC conditions. And that becomes significant when we treat missing with multiple imputation on the right there. When we look at cigarette-free days, so these are just days of cigarette abstinence, you can see significant increases in the groups that received very low nicotine content cigarettes during the study period, regardless of how you treat missing data. And then the same story holds true for mean cigarettes per day. Among those who continued to smoke, we saw the greatest reduction at follow-up in the immediate reduction condition, groups that immediately switched to VLNC cigarettes, followed by gradual reduction with the control condition doing the worst. Now, if we look at abstinence over time during that follow-up period, I think this is interesting because we had this intervention where people switched to low nicotine cigarettes, and then it's worth examining how abstinence changed during the 27-day period where there was no intervention. And first and foremost, there was no interaction, indicating that the decline in abstinence, first off, was small, but second off, didn't differ between conditions. And to me, this tells me that there is some sustained effect from a brief period of being exposed to VLNC cigarettes. So what can we draw from this study? First, this demonstrates, as I just mentioned, some sustained effects from a period of nicotine reduction, of switching to VLNC cigarettes, with the greatest benefit from immediate reduction. And it's consistent with a likely mechanism where more exposure to the least reinforcing cigarettes is associated with faster and greater extinction, which you would expect to translate to days of abstinence, cigarette reduction. And I think this shows a bit of a signal um, suggesting that VLNC cigarettes could be used to augment tobacco treatment. It's not how they were used in this trial, but again, we're seeing there was some quitting after the trial. And then finally, it provides further support for the regulatory or the policy intervention for a reduced nicotine standard. So next, I wanted to ask a similar question with a more recent study. Again, this one led by Dorothy Hatsukami, published just last year. And here, participants were randomized to switch to VLNC cigarettes or normal nicotine content cigarettes, but they all had exposure to a marketplace with alternative nicotine delivery systems, so non-combusted forms of nicotine. Now, it's worth noting here that there's non-combusted forms of nicotine, like e-cigarettes, are likely substantially less harmful than combusted cigarettes. So a switch from combusted to non-combusted would represent harm reduction. The marketplace that all participants in both conditions were exposed to resembled an online retail store, and they could choose between e-cigarettes, smokeless tobacco, pouches, NRT, and so on. The primary outcomes from the parent trial were very promising, showing the greatest reduction in in cigarette smoking in the VLNC condition, represented in blue there, as well as the greatest increase in cigarette abstinence in the VLNC condition, again, when everyone had access to these alternative nicotine products. Another finding was that there were quite a few people who at the end of the study were co-using both cigarettes and a non-combusted form of nicotine. So that's represented in the orange line, separated by condition there. And collapsed, we see a little over 1/3 of participants in this trial ended the study co-using their study cigarette plus one or more non-combusted nicotine product. And so from that, we got interested in asking two questions. The first was similar to the last secondary analysis, which is, do we see sustained effects of switching to VLNC cigarettes, this time with access to alternative nicotine delivery systems, or ANDS, at the 16-week follow-up? And the second is, among those who self-selected co-use by the end of the study, are we seeing lasting effects from that at the week 16 follow-up? And again, participants did not receive study product during the follow-up period here. So to start with, just want to focus on co-use at the end of the study period. So what did it look like when people were using study cigarettes and non-combusted alternatives? Well, among those who were assigned to VLNC cigarettes, they had more days of non-combusted alternatives, ANDS, than those assigned to normal nicotine content cigarettes. There was no difference in the days of cigarette smoking between co-users of VLNC cigarettes versus normal nicotine content cigarettes, but those who were co-using with VLNC cigarettes smoked fewer cigarettes on days that they smoked. And we see the most common ANDS product was e-cigarettes, followed by NRT. This did not differ between conditions. Okay, so moving on to follow-up results here. I'm going to present findings both by VLNC condition and by co-use status. The VLNC versus NNC is represented in blue, and you can see that there was some sustained effect of being exposed to VLNC cigarettes, where we see a greater likelihood of 7 to 8 point prevalence abstinence at follow-up in that condition. There was no effect on 7 to 8 point prevalence abstinence over here in the red from co-use at the conclusion of the study period. With regard to quit attempts, we see numerical difference in the study condition, but not significant. But we do see a significant effect where those who self-selected co-use by the end of the study period were more likely to make a quit attempt during follow-up. With regard to smoke-free days, we see a benefit to both VLNC condition as well as co-use at the end of the study period. And the same story is for cigarettes per day, where we see a benefit in the VLNC condition, as well as among those who were co-using at the conclusion of the study. None of these interactions were significant. So what can we learn from these main effects here? What can we learn from these findings? First, I think this demonstrates, again, sustained effects from a period of nicotine reduction, but this time with access to an array of non-combusted alternatives. And we see that co-use at the end of the study period was associated with reduced smoking, quit attempts, and more smoke-free days at follow-up. And so I think this provides a nice signal for VLNC cigarettes to augment harm reduction effects in people who smoke cigarettes. And of course, further supports the reduced nicotine standard from a policy perspective. Okay, last analysis I want to talk about today, again, focused on VLNC cigarettes. Ooh, this is a little blurry. Sorry about that. This is a secondary analysis of a paper that Steve Higgins led right out of our center here, focused on three randomized clinical trials of high-risk populations who were switched to VLNC cigarettes with or without e-cigarettes and with or without flavors. So these were 326 adults, and they were randomized to one of the four conditions you see here on the screen. Normal nicotine content, very low nicotine cigarettes with tobacco-flavored e-cigarettes, or low nicotine cigarettes with preferred flavored e-cigarettes, and they could choose their flavor from a range of options here. At baseline, none of these folks were motivated to quit, and none of them were regular e-cigarette users, but they were all regular cigarette smokers. Now, the primary outcomes from this paper, which was again published last year, were very compelling. First, replicated effects from VLNC cigarettes alone. And you can see this is total cigarettes per day. VLNC cigarettes are the orange dots. Normal nicotine cigarettes are the black dots. But you'll note that those who received preferred flavored e-cigarettes did even better than those who received VLNC cigarettes or VLNC cigarettes with tobacco flavored e-cigarettes. And the same effect was seen in NNAL, which is a biomarker of tobacco exposure. Okay, so we wanted to dig deeper on this and try to understand what was the mechanism driving this effect to, again, give some indication as to how these data could be used for people who are not motivated to quit. So if you look in the literature on self-selection of e-cigarette use in natural large observational studies, there's a fairly consistent finding that greater frequency of e-cigarette use is associated with greater reduction in cigarette smoking. So we hypothesized that perhaps the frequency of e-cigarette use was the mechanism driving the effects of appealing e-cigarette flavors on reduced smoking in this study. So from that comes a mediation model where we hypothesized in those conditions that received e-cigarettes, those who had access to their preferred flavored e-cigarettes would use it more frequently, and then more frequent use would drive down cigarette smoking. So to test this, we first examined the A path of the mediation analysis to say, did people who got access to preferred flavors actually vape more? And they did. The finding was consistent across weeks here. This was a 16-week trial. And you can see those in the black dots represent the frequency or the mean days of e-cigarette use across study weeks. And people who had access to preferred flavors significantly used their e-cigarettes significantly more days than those who only had access to tobacco flavored e-cigarettes. Okay, so next we wanted to see, in this trial, did increased use of e-cigarettes result in a reduction in smoking? Again, keeping in mind that these were people who didn't intend to quit at baseline and were not regular users of e-cigarettes at baseline. And we looked at this in a handful of different ways, binary, continuous, and categorical variable. Here I'm presenting categorical data because I think it illustrates the effect quite nicely, but the effect was consistent across sensitivity analysis. But what you're seeing is that with cigarettes per day on the left, a greater frequency of e-cigarette use along this axis here was associated with a greater reduction in cigarettes per day, as well as a greater reduction in NNAL, and these were both highly significant. So coming back to our overall mediation model, we then wanted to test full mediation, so whether the effect of e-cigarette flavor was mediated by frequency of e-cigarette use. To do this, we conducted two models. The first was for reduction in cigarettes per day, and here we saw significant full mediation. E-cigarette use frequency was seen as a mechanism driving the effect of preferred flavor versus tobacco flavor. And when it came to NNAL, we saw partial mediation, but it still was significant, indicating that NNAL played a role, e-cigarette frequency played a role in reducing NNAL. So, this really supports the model that among adults not ready to quit, if we can reduce the reinforcing effects of the most harmful product, which is combusted cigarettes, and increase the reinforcing effect, through flavors or other means of less harmful products, e-cigarettes. It is an effective way to drive down cigarette smoking, which of course is the goal here. So implications, I think this provides support for reducing, as I mentioned, the reinforcing effects of cigarettes, along with introducing appealing e-cigarettes. It also provides some initial support for a causal relationship here, where we've seen this in the literature and observational research. And it provides support for use of appealing e-cigarettes in combination with VLNC cigarettes for harm reduction interventions. So as I mentioned, this was really a test of policy and supporting a nicotine reduction standard. But I think this also provides a signal for ways that we could be using these tools in clinical practice. Okay, so I want to take a step back here. This is my last slide, and just try to tie up all the different projects I've talked about over the past 45 minutes or so. And I think there are a couple of important take-homes from all this. First is, on any given day, most adults who smoke cigarettes are not motivated to quit right now, are not ready to quit right now. However, and I think this is the most important, we need not wait for motivation to promote quitting. We see in these natural history studies that there are quite a bit of fluctuation day to day. And so I think, if we as providers come into contact with adults who smoke, who are not motivated to quit now, anything we can do to provide them with the tools to increase the likelihood of quitting at some future date is hugely beneficial. Now, reducing cigarettes per day is a very common approach, difficult to induce experimentally here, but we see among those achieving greater magnitudes, specifically maybe above that 45% threshold, as Tony Barrows showed in his latent class analysis. Among those who can achieve that high magnitude of reduction, we do see the needle being moved in terms of likelihood of quit attempts and subsequent quit success. And meta-analyses demonstrate that despite the variability in this body of literature, reduction interventions are about as effective as abrupt interventions. There's a substantial body of evidence to support a nicotine reduction standard as a population level intervention. And I think in some of these secondary analysis, we are seeing a signal that this could be used to augment existing efforts to provide treatment or harm reduction for individuals who are not actively ready to quit now or engaged in evidence-based treatment. So with that, I will end. There's so many people to thank in terms of our center and contributing to this body of work, all listed there on the left there, as well as my fantastic lab pictured on the screen with our newest addition, Rhiannon Wiley, who just joined a few months ago. So I'll stop there and would be happy to take any questions. Thank you.
Well, thank you, Eli. It was really a terrific talk, very, very stimulating. So we have three questions waiting for you, and I'm going to take them in the order in which they came in. So the first is from David Drobes, and he says, "Hey, Eli, enjoying your lecture. Do you differentiate these reduction studies from earlier nicotine fading treatments?"
Yeah, that's a very good point. And I think there are important differences, but I think they all get at the same core concept, which is so this idea of cutting down to quit. And importantly, they were all included in that meta-analysis led by Nicola Linzen and the Cochrane group. So I think, combining some of the more recent reduction studies with some of the older ones, we still come to this conclusion that reduction interventions are at least no more harmful than abrupt quitting. And so if we end up with someone who's not engaged in treatment or ready to quit now, reduction intervention could be the way to go.
Great, thanks. So now the second question from our former UVMer, John Roll, who's out in the state of Washington sending questions. Thank you for an excellent presentation. Given that co-use of cannabis and/or alcohol with nicotine may enhance nicotine's reinforcing efficacy, do you think it's important to address these other types of substance use among this population in order to facilitate nicotine abstinence?
Absolutely. I think that is very important. And I know there's some work being done on both. At the very least, should be assessed. And importantly, my understanding is one target shouldn't be delayed in order to prioritize the other. So the extent to which we can address substance use together, I think, is helpful. So I think, when it comes to smoking, um, a big first step, as I've talked about today, is simply engaging people in a process that will help them get over that hump to make a quit attempt. I'd be interested to see, especially in this population that co-uses both, how the processes of engaging in making a quit attempt for cannabis or alcohol are similar or different than the processes that I've talked about today in engaging people in making a quit attempt for cigarettes. So I think that would be an important line of work to be done there.
Great, thanks, Eli. So I just want to encourage the audience. We still have 10 minutes for Q&A. So Eli, you did a great job of staying on time and allowing plenty of time for Q&A. So we have a question here from Wasantha J. Awardine, and thanks for the excellent presentation. I'm from Southern Illinois University in Carbondale. Can smokers who failed to quit after a reduction have lower odds of making subsequent reduction attempts, possibly due to disappointment or reduced motivation, or are they more likely to make future reduction attempts regardless, increasing the overall chances of quitting?
Yeah, that's a really good question. And my understanding of that literature is a little bit inconsistent and depends on how you measure these things. So in the body of work on natural history research, which I like because it's a prospective assessment, nightly, fine grain, and captures even the smallest quit attempts, or at least it aims to capture that. In that body of literature, reduction episodes and failed quit attempts increase the likelihood of subsequent quit attempts and even increase the likelihood of subsequent success. And so that's encouraging for me to say, let's just get people to try with the explanation that it's a chronic process and we'll need to have them try again. Now, Ron Borland has done some work where I think it's an inverted U-shaped curve where at a certain point, there's so many quit attempts that if they haven't been successful at that point, you sort of get some diminishing returns. So I think that's important to keep in mind. But definitely when you're starting off engaging someone, um, we want to send that message of try and try again.
Great. So we have another question from a former UVMer again. So you're getting good support. This is Dennis Hand sending questions from Philadelphia. Great talk, Eli. Controlled environments, that is residential treatment, for example, force reductions in smoking by limiting access. Would this similarly promote quit success, or are there other factors in play?
That's a really good question. I don't know. And that would be a really nice test of a mechanism. So forced reduction, where you don't have access and you have to cut down for reasons other than changes in your own motivation or desire to quit or movement toward quitting, would that have the same effects as someone either self-selecting to reduce or reducing as a result of a clinical intervention? And I don't know the answer to that, but I would be excited to read that paper.
Yeah. You and me both. I mean, the first thought that comes to my mind is the power of stimulus control. So doing it in one set of stimulus conditions and hoping it to transfer is very different than doing it in the conditions, under the conditions in which you want it to sustain. But great, research question. So thanks, Dennis. Any
It's a
other
good.
lingering questions out there?
Well, I want to
Yeah,
sort of
please.
speculate a bit more about
Yeah,
that
yeah,
question.
yeah,
I think
please
it's an
do.
interesting one. Yeah, it is. What you just pointed out is a really good point. A counter hypothesis there is some of the benefit from reducing could be simply gaining experience with internal stimuli or external, um, not smoking when you really want to smoke or when you have cues that prompt you to smoke. And so getting the opportunity to practice despite feeling the urge or craving to smoke, practice not smoking, may be where some of that benefit comes in or might be help to build some efficacy. But ultimately, it's an empirical question. I think what Dennis pointed out would be a good way to test that.
Yeah, absolutely. Okay, so James Thrasher has come in. Can you talk about typical counseling content in smoking reduction interventions? Does it explicitly address reduction as a stepping stone towards quitting?
Yeah, so it's been done in a couple of different ways. There are two primary, I think in the literature, two primary reduction counseling approaches. One is a timed reduction where you take the number of cigarettes per day someone typically smokes and you ask them to spread that out across their waking hours on an alarm. And then you gradually increase the time between each cigarette. So you start to break up cues between what would have otherwise prompted smoking and actual smoking, and then also driving down the number of cigarettes per day. The other is a hierarchical approach where you work with the patient to identify the cigarettes that are easiest to give up to hardest. So maybe your easiest is that third cigarette you have on a smoke break. And then, in an attempt to build self-efficacy, you slowly cut out the easiest cigarettes, working your way up to the hardest cigarettes. Now, this question of whether counseling is framed with the explicit goal of a quit attempt or not is an interesting one. And I've seen it done both ways. And I don't know which is more effective. An argument for not explicitly promoting a quit attempt at the outset is it's a foot in the door. These are often, at least in the context we're talking about today, people who are not interested in quitting now, not engaged in treatment to quit now. And so saying, okay, we're going to give you some counseling to help you quit might be aversive or send that person away. So I could see not bringing it up as a way to engage people. Alternatively, um, if someone mistakenly views reduction as a sufficient alternative to quitting, that could do harm because we don't want someone thinking, okay, I've made a little bit of change. That's enough. I don't actually have to go ahead and quit. We know that we really want to achieve cigarette abstinence. So it's a great question, and I think we need some more research to get to the bottom of that one.
Well, I don't see any questions here, but we do have a couple minutes. So I'm going to take the liberty to ask you a question. I'm still pondering Dennis Hand's question. So, has anybody collected data now that when you're hospitalized, at least here in the United States, most times the hospitals do not permit any smoking, and I'm under the impression that that's adhered to very well. Are quit rates upon discharge any higher with that policy than they are in countries that don't have that policy, or if there's any data pre-policy?
Another great question, and another one I don't have the answer to off the top of my head. Thinking about it out loud, it seems like it is a question that the data exists. We could look into that. It would be challenging to tease apart effects of time and things that have changed with regard to change in policy in the U.S. or effects of environment if we're looking across countries. But it seems like we could, drill down on that question and it would start to get at this question of whether forced periods of reduction or abstinence have similar effects from periods of reduction or abstinence induced by counseling or self-selected.
Yeah. Yeah. And especially when you think about them offering NRTs. So don't worry if you're having withdrawal symptoms. We're going to give you medication that can ameliorate them, so they get to experience that those medications have efficacy. You might think that would be helpful. All
Well,
right.
one thing I am sure of is that that practice does increase quitting compared to not doing that practice. The question that I think I'm not as clear on is whether reduction in those settings, how that compares to reduction in self-selected settings. So just want to draw that distinction. I think what you just mentioned about NRT distribution in hospital settings, not smoking in hospital settings, that's a huge benefit and does increase quitting and reduction. But how that compares to other settings for reducing, I'm not sure on.
Great. Well, we are about out of time, so I want to enthusiastically thank you, Eli, for a terrific talk, and our audience for their great attention and great questions. So don't forget to join us back again in January on the 21st. So thanks to everybody, and we're going to sign off.
Thanks.
Yeah, and happy holidays.